Hello, my name is Hana Getahun, and today I'll be presenting a quality improvement project on a risk stratification algorithm for surgical patients on GLP-1 agonists. I had the pleasure of doing this project with Dr. Ann Miller. The learning goals for this project are to define GLP-1 agonists, to understand the different drug regimens and duration of action, discuss the benefits of an algorithm for risk stratification of patients on GLP-1 agonists, understand the risk of aspiration that comes with this patient population, and recognize the need for a clinical guideline for a systematic assessment of risk stratification for preoperative management of patients on GLP-1 agonists. So for some background information, glucagon-like peptide 1 is a postprandial hormone that stimulates insulin secretion, reduces glucagon excretion, inhibits gastric emptying, and increases residual gastric content. This class of medication has been the mainstay of management for patients with diabetes type 2, but recently the FDA has approved it for weight loss management in obese patients without diabetes. So these patients that are non-diabetic, obese patients trying to lose weight will come into our preoperative area that have fasted for 8-10 hours and still present as a full stomach with residual gastric content and are at increased risk for aspiration during induction of anesthesia. There's a significant death rate associated with anesthetic airway management complications in the perioperative area with aspiration of stomach contents, which can cause major pulmonary sequelae. As I mentioned before, GLP-1 agonists were historically used for type 2 diabetes management. It was first approved by the FDA in 2005 because they help control A1C and they reduce postprandial hyperglycemic events. The scope of the problem has recently been expanded to non-diabetic patients. The FDA recently approved a higher, more potent dose of GLP-1 agonists for chronic weight management in overweight and obese adults in 2014. This is a table of the different GLP-1 agonists out on the market in different formulations. I wanted to point out that under the mechanism of action, they all slow gastric emptying or delay gastric emptying in some way. Also, it's important to note the frequency of administration. Some of these are weekly, some of these are daily, and so when we look at our algorithm, we'll kind of see how often the patient takes it and how long they should hold it for. These are the 2017 ASA fasting guidelines that we currently follow in our preoperative management of surgical patients. We want to make sure that our fasting recommendations are followed with the minimum fasting period, and we can also give our gastric acid secretion blockers or antacids and antiemetics preoperatively as well. GLP-1s delay gastric emptying, and that can lead to an increased residual gastric volume regardless of how long the patient has fasted. This increased residual gastric content can lead to aspiration during the induction of anesthesia. Aspiration of gastric content during induction can lead to complications such as hypoxia, pulmonary edema, pneumonia, and atelectasis. Furthermore, intraoperative complications can lead to a longer hospital stay, ICU admission, higher healthcare costs for both the provider and the patient, and overall poor patient outcomes. For patients taking GLP-1 agonists for diabetic management, it's important to avoid abrupt withdrawal of these medications because it can elicit hyperglycemic complications that can lead to kidney injury, cardiovascular disease, and neuropathy. So it's important to do a preoperative gastric ultrasound on these patients to either confirm or rule out the presence of gastric contents before they go in for surgery. If you see gastric contents that are visualized on the ultrasound, the anesthetist is advised to use rapid sequence induction with cryogenicity pressure to avoid aspiration of gastric contents. These are the preoperative fasting recommendations put forth by the ASA Task Force in 2023 for patients on GLP-1 agonists. They say days prior to the procedure, for a patient that's on daily dosing, consider holding the GLP-1 on the day of surgery or the procedure. For patients on weekly dosing, consider holding the GLP-1 for 1 week prior to the procedure. This is irrespective of the indication, whether the patient is taking it for diabetes management or for weight loss management. They do say, though, for patients that are on GLP-1 agonists for diabetic management, you may want to consider consulting an endocrinologist to bridge the anti-diabetic therapy to avoid hyperglycemia. So once a patient arrives, it's the day of the procedure. If they present with a GI symptom such as severe nausea, vomiting, retching, abdominal pain, or they feel full in the stomach, you may consider delaying the elective procedure. If the patient has no GI symptoms on the day of the procedure and they've held the medication as advised, you can proceed as usual. If the patient has no symptoms but the medication has not been held as advised, you can proceed with a full stomach precautions or consider evaluating the gastric contents with a gastric ultrasound. This is an example of a risk stratification algorithm utilizing the ASA Task Force preoperative recommendations for patients on GLP-1 agonists that was released in 2023. So this is an easy to follow algorithm that once you meet your patient in the preoperative area, you can ask them, are they on a GLP-1 agonist? Are they on Ozempic? Are they on Wegovy? Are they on any one of these? And what type of dosing is it? Is it daily dosing? Is it weekly dosing? Have they held it for a day? Have they held it for a week? If it's held as advised, you can continue with the case, but consider an RSI as extra precautions. If they have not held it for the advised amount of time, you can consider a preoperative gastric ultrasound. Using the gastric ultrasound, you can assess their gastric volumes. If it's less than 1.5 mLs per kilogram, you can continue with the case and also consider RSI as well. If it's greater than 1.5 mLs per kilogram, then you want to consider either canceling the case, delaying the case for maybe a couple of hours, and consider full stomach precautions. As a refresher, this is the ultrasound of the gastric antrum. It's considered an empty stomach if it's less than 1.5 mLs per kilogram, and it's considered a full stomach if it's greater than 1.5 mLs per kilogram. To conclude, the use of GLP-1 agonists for weight loss and weight management has been recently and rapidly popularized on social media and other outlets. Many of our non-diabetic patients are arriving to our preoperative area with full stomachs and increased aspiration risk. It's important that our anesthesia providers are made well aware of the possible complications on induction of anesthesia. Ideally, a clinical guideline would be useful to have fasting recommendations and preoperative gastric ultrasound usage in this patient population. The education and spread of awareness on GLP-1 agonists for weight loss can assist anesthesia providers in providing quality, safe, patient-specific anesthesia care. These are the references used in this presentation. Thank you so much for watching, and if you have any questions, please don't hesitate to ask.